Hello, everybody, and thank you for joining us. My name is Ryan McGee, and I am the Communications Manager for WellcomeMD. We are very pleased to have Dr. Courtney Palmiere join us today, and she's going to talk about our hearing health and kind of the things we have to watch for and when we should start being concerned about our hearing. Here to introduce Dr. Palmiere is our membership expert, Tara Greenberg. So take it away, Tara. I know that this is a topic that is near and dear to you.
Yes, hi. Thank you all for joining us today. As Ryan said, this topic is near and dear to me. One of my responsibilities is to put together health-related educational programs for the community. And the reason why I wanted to do this particular topic is that my own father was recently diagnosed with a brain tumor. He is very good about hiding symptoms. He had had hearing loss and had just gone to have his hearing aid adjusted rather than going to an audiologist or to his primary care doctor. And probably a month passed before he saw his concierge doctor on an unrelated issue. And because we always look at the cause and not just treating symptoms, his doctor took the time and actually sent him for the test necessary to diagnose him with the brain tumor. And he is thankfully undergoing successful treatment today. When looking at developing this program, I wanted to work with an audiologist who shared that philosophy, who really wants to know what's causing an issue, not just putting a Band-Aid on a symptom, but really getting to the core. And I'm very fortunate that Dr. Palmiere agreed to be with us today. I think you'll all find this a very interesting and important presentation. And thank you again for your time, Dr. Palmiere.
Yes, thank you so much. So hi, everyone. Welcome to today's seminar. My name is Courtney Palmiere, and I'm an audiologist at Audiology of Charlotte in the Piper Glen area of Charlotte, North Carolina. And today we are going to be talking about a comprehensive approach to hearing health. So just a little overview of what to expect throughout this presentation. So first, we're going to be going over what an audiologist is, then the hearing loss, types of hearing loss, and the parts of the ear, and what's involved in our hearing evaluations. Then we're going to review some comorbidities of hearing loss and what I look for when I'm doing a case history. And then the signs of hearing loss that you can look for, and when is it time to really, something that is a really big red flag, you need to go see somebody right away. And then lastly, we're going to wrap it all up and talk about the idea of treating the whole patient instead of just the symptom. A little bit about me. So I am, again, an audiologist. I was originally from outside of Philadelphia, and I attended the University of Maryland for my undergraduate studies. And then I moved to Pittsburgh, and I got my doctorate at Pitt. And then I was in the ENT world for a little while, and then I had the opportunity to switch over to the private practice world, which is really what I've always wanted to do. I love the idea of following my patients throughout their hearing journey, taking the time I need to really get to know them, get to know what other problems they're having other than hearing loss, and really take the time to make them know that I care about them and I'm trying to help them overall and help them succeed. So that really gets to my why. So I started audiology because I helped my grandmother through the process of getting a cochlear implant. And I've also helped my grandfather go from Costco hearing aids to prescribing and fitting him with hearing aids myself, and really watching them, socially engage, their quality of life getting so much better, and their happiness just getting so much better. So all of those reasons are why I, solidified my passion for audiology and why I want to help every patient of mine really succeed and get their quality of life back to the way it used to be. And then lastly, this is just a picture of myself and my husband. We got married last year over Labor Day, and we've been in Charlotte for about 2 years, and we love it. We moved here to be closer to my family, and it's been wonderful so far. So first, let's just review what is an audiologist. So sometimes you can go to a practice that has audiologists. Other times you're going to practices that have hearing aid specialists or hearing aid dispensers. So what an audiologist is they're a state licensed healthcare professional who holds either a doctoral degree or a master's degree in audiology from an accredited university. So it's changed in the past several years to needing a doctorate. So you go to your undergrad and then you get 4 years of graduate program, and then you do a residency. So an audiologist can perform any of the following functions. So diagnosis of hearing loss, they can prescribe and fit hearing aids, assisting cochlear implant programs, perform ear or hearing related surgical monitoring, design and implement hearing conservation programs and newborn hearing screening programs at all the hospitals, and then also anything having to do with oral rehabilitation. So auditory training, tinnitus therapy, misophonia, and speech reading. Overall, my end goal for all of my patients is to educate you on what I find during the hearing evaluation and your case history, and educate you on all the different options that you have for treatment so that you know and you're able to pick the best option for you. And I'm here as a vehicle to recommend what I find would be best for you based on your hearing loss and your lifestyle. And I just want to optimize your hearing, but also optimize your overall health. Hearing aid dispensers, they are here for strictly to prescribe and fit hearing aids, right? So they went to a program that would teach you how to prescribe and fit hearing aids. They're not on the lookout for other underlying reasons that this hearing loss could be happening. They don't really have in the back of their mind thinking of red flags that can pop up. When a patient comes into my office, I'm constantly thinking about red flags, if I need to refer, if there's something else going on. So you want to make sure that you're going to someone who has your best interest at heart. And they're not just trying to cover up your hearing loss with a pair of hearing aids and sending you out the door, but they're really, really trying to, treat your hearing loss, of course, but also find the root of the problem and treat anything else that might be exacerbating your symptoms, right? And I know that you all know with WellcomeMD and concierge services, they have that same value, right? They're always looking for the underlying cause. They're always looking at that whole patient and trying to get to the root of the problem. All right, so I figured I would go over the parts of the ear because I feel like not a lot of people know a whole lot about that. And also the different types of hearing loss that you'll probably at some point see in a family member or yourself or a friend, right? So there's 3 parts of the ear: the outer ear, the middle ear, and the inner ear. The outer ear is what we all think of when we look at the ear, right? So it's the pinna and the ear canal. And then it ends with the eardrum at the end of the ear canal. The eardrum is what separates the outer ear and the middle ear. The middle ear is this cavity of space here, and it holds the 3 smallest bones in the human body. And these bones work together to transfer energy and sound energy from the eardrum to the inner ear. So when a child has an ear infection, it's usually due to fluid that goes up and gets trapped in this middle ear space, and it gets infected. And what happens is it keeps these middle ear bones from moving the way that it's supposed to be, causing it to sound like that child is hearing underwater almost. And it can really affect a child's development if they have a lot of ear infections over time because they have a hearing loss too. And then the inner ear, it holds the balance organs, which are these semicircular parts right up here. And then it has the hearing organ, which is the snail-shaped part right here, and that's called the cochlea. And the cochlea holds all these tiny little hair cells that can stimulate hearing, and they all have to do with the different pitches of hearing loss. And these hair cells send signals up to the brain, so that the brain knows that you're hearing something. What happens are these hair cells can die, and that's what causes a permanent hearing loss. So when the hair cells die, it depends on the type of hair cells that die, and that coincides with the pitch of the hearing loss that you have, because each hair cell has to do with a pitch. So now going into the types of hearing loss, the first is sensory neural. That's the most common type of hearing loss. It's permanent and sometimes preventable. So a lot of times it's due to aging and it just slowly progresses over time. It can also be due to viruses or genetics. Maybe you just have a family history of hearing loss and you get a sensory neural hearing loss quicker than normally what a normal person might have a hearing loss. Saying that it's sometimes preventable, sensory neural hearing loss can also be due to noise exposure. So if you make sure that you're wearing hearing protection when you are shooting a gun, when you're at a noisy concert, mowing the lawn, anything with high levels of noise, noise exposure can be preventable, and a noise exposed hearing loss can be preventable by doing things like that. What happens with this hearing loss is, again, that those hair cells in the cochlea die, and there's no medical or surgical treatment option, right? We don't know how to regrow those hair cells yet. So hopefully sometime in the future, we'll be able to regrow those hair cells, but as of right now and the foreseeable future, unfortunately, that's not an option. So the primary treatment for this type of hearing loss at this point are hearing aids. The second type of hearing loss is conductive. So that occurs when sound waves are prevented from reaching the inner ear. So like I said before, let's say a child has a middle ear infection, that keeps those bones from moving the way they should be, and it causes a conductive hearing loss when that child has an infection. Or let's say you have impacted wax in the ear. There's so much wax in the ear that it fills up the ear canal and sound can't get to the eardrum the way that it should be. That will cause a conductive hearing loss. So in most cases, we can treat the problem that's keeping the sound from getting to the healthy inner ear. And once you treat that problem, then they're able to hear again, and it's treatable. And then the last type of hearing loss is a mixed hearing loss. So that has both sensory neural and conductive components. So maybe they have some noise damage and then they also have an infection, something like that. So they're both of them working together. All right, so we'll go into what's involved in a hearing evaluation. So during a hearing evaluation, the audiologist is not only looking for the degree or the severity of the hearing loss and the type of the hearing loss that is present at the time, but also we're looking for any red flags or signals that rise to me that say, I need to refer, or maybe there's something else going on that's deeper here. So prior to the evaluation, I'm having my patient fill out a lot of medical forms and new patient forms that go over different kinds of health factors that they're going through or their medical history, so that I can start to review that and see what other questions I need to ask during that case history. And then during the case history, I'm really getting deep into any other questions or blanks that I have at that point, and really getting to know, what their listening needs are, when this hearing loss started, if they have any other symptoms like tinnitus, pain, anything like that. So I can really get a full idea of what has been going on. Next, I'll do a visual examination of the eardrums and ear canals. I'll make sure that there's no wax that needs to be removed that can impact the results of the test. There's no fluid present, there's no drainage, nothing like that that can really interfere with the test or anything that I need to refer directly to get treated. And then I will start the actual hearing evaluation. So I'm sure you all are familiar with the beep test. So I present a bunch of beeps and I have you press the button whenever you hear it. I'll also have you repeat back some words and then also some sentences. And you're in a soundproof booth, so it's very quiet, but I will put in some noise at some point so that I can see how you're doing in noisy environments as well. At the end of this hearing evaluation, I have a good idea of the degree of hearing loss, the type of hearing loss, and what I need to do for referrals. On the right is an audiogram. So that is a graph of how I plot a patient's hearing loss. So from the left side of the graph to the right side of the graph, it goes from very low pitch sounds to very high pitch sounds. And then from the top of the graph going all the way down to the bottom of the graph, it goes from very, very soft sounds like the rustling of leaves to extremely loud sounds like a gunshot or fireworks. And you can also see that on this audiogram is different speech sounds in the English language, and it's plotted all across the audiogram. And then also familiar sounds that we hear every day, right? So a dog barking, people whispering, birds chirping, and they're plotted where they will be on and how loud it is and what pitch it is for a normal scenario. So when I plot a patient's hearing loss, I can show them exactly what they're missing based on, the degree and in what pitches it is, so that they can have a better idea of, okay, I'm missing the consonants, but not the vowels. I'm missing, my grandchildren's voice, or I'm missing the birds chirping outside, things like that. So it gives them a better idea of what they're actually missing than just, telling them a degree of hearing loss, because that's kind of hard to conceptualize sometimes. So once I get all this information, I'm able to make the best recommendation that I have for them. So if hearing aids are recommended, the style, the type, and then also I can say, hey, this is also going on right now. So what else do you have going on? And I need to refer you to this doctor, or I need to talk to your doctor that you're already getting treatment with, so that I can co-manage this problem with them. Speaking of referrals, so when a patient is filling out their new patient forms and I'm taking a case history, I'm really on the lookout again for these red flags, or there's comorbidities. A comorbidity is a simultaneous presence of two or more chronic conditions or diseases in a patient. So from the diagram on the right, as well as the list on the left, you can see there's a whole bunch of comorbidities to hearing loss that give a higher likelihood of having hearing loss with these other diseases. So first, cognitive impairment and dementia. So you have a higher likelihood of cognitive impairment and dementia if you have a hearing loss. So I put the quote, "You do not hear with your ears, but you hear with your brain." So the idea is that if you have a hearing loss, your brain is not being stimulated in certain parts that it used to be. And that can really cause cognitive impairment. It can cause social isolation, and it all starts to work together until it's a whole body problem. When you get hearing aids, your brain is being stimulated again where it wasn't before, so that you're more engaged in social activity, you're more engaged in day-to-day life. Even just, being able to hear the birds chirping, the refrigerator running, that's all subconsciously just stimulating your brain, and that's all very, very healthy, and your body needs that. So without that, it can cause a lot of problems. Depression is a big one. So hearing loss leads to social isolation and loneliness, which leads to depression, and anxiety of not being able to hear others, not being able to hear your doctors. All of these things are very anxiety inducing, not only for yourself, but for your family members, for your friends, for your partner. All this really affects everyone in your social circle. Also, those with hearing loss have a higher risk of falling. There's actually hearing aids available now that when have fall detection. So when you fall, it will send a text message to a family member or a partner that will give them an alert that you have fallen, and so that you can take the correct measurements to make sure that they're okay. Because this really is a big problem, especially as you get older and you have hearing loss. Cardiovascular disease is a big one. So strokes, heart attacks, coronary artery disease, these are all considered a comorbidity. And there's actually a type of hearing loss that you don't see very often, but when you do come across it, it's been found to be linked to cardiovascular disease. So a hearing loss that is in the low pitches or the low frequencies can be seen as a precursor or to somebody who will eventually have cardiovascular problem or has a cardiovascular problem now. So again, I said the ear is the window to the heart. So when I see this type of hearing loss, even if my patient didn't say that they had any cardiovascular problems, I'm referring out to a doctor to get a better look at what's going on. And I'm letting them know that this is a precursor and could be a precursor. So it's in the back of everyone's head to keep an eye out for this. Also, diabetes. People with diabetes have a higher likelihood of a high-pitch hearing loss, a high-pitch sensory neural hearing loss. So anyone with diabetes, I recommend getting a hearing test every year, 6 months to a year really, to make sure that there's been no changes in their hearing, and make sure that everything is still staying healthy. And then lastly, kidney disease. So with kidney disease, it can damage nerves, and those nerves include the inner ear. So anybody with kidney disease, we want to make sure that they're getting their ears checked to make sure that they don't have a hearing loss that needs to be treated. If I see anybody with these diseases or symptoms present, I usually ask my patient, what are you doing right now to treat these symptoms or these diseases? I see what they say, and then I kind of know where to go from there. If they already are being treated, then I make sure to reach out to their doctors and let them know what's going on with their hearing. What is their communication problem right now? What do they need help with when face-to-face interaction, quiet room, all of these tips that will help them hear better in these kind of situations. And I also keep them updated about their hearing loss, if there's been any changes in their hearing, when I do consecutive audiograms, things like that. So, and if they're not getting any treatment, then I'm referring them out to get a better look so that they can really make sure that, they're getting to the root of the problem and they're getting the treatment that they need to help with their overall health. All right, so know the signs. So what should you be looking for? The most common hearing loss is progressive, right? It's gradual, it's progressive, it's due to aging or genetics. This can be hard to one day, just know that you're starting to get a hearing loss and make an appointment and come in. It's gradual, and it's usually in the high pitches. So you're still able to hear pretty well, but the clarity of the speech is gone. And it gradually over the years starts to progress and worsen until you get to the point where that threshold where you really notice a problem, it's really starting to affect your day-to-day life, and you know that it's time to come and get your hearing checked. That timeline is 7 to 10 years. So the average person waits 7 to 10 years once they start to notice maybe they're having a little bit problem, to the point where they say, or their wife or husband says, you need to go and get your hearing checked. You need to get some hearing aids, right? So things that you'll start to notice. The biggest one is trouble hearing in noisy environments. So maybe you're fine when it's one-on-one or you're in your house with your spouse, but when you go into a restaurant or you are at work in conference meetings or at church, anything like that, you start to really notice that you're having a hearing problem because you really can't engage in the conversation. Difficulty hearing people when they're not looking at them. So maybe somebody's yelling for you in another room, or maybe they're washing the dishes and talking to you at the same time, and you're really having a hard time hearing. Family members and friends are going to start to notice an issue. So maybe family members are repeating themselves more often. Maybe they're mentioning that you're having a harder time understanding them. It's usually the family members that notice the hearing loss before the actual person does, because they're the one having to repeat themselves all the time. And maybe, your television is being turned up a lot louder, and your spouse is telling you to turn down the volume because it's so loud. Those are all signs of progressive hearing loss, and signs that you could really be stimulating your brain and getting better time with hearing and noise and things like that if you get your hearing checked and you get it treated. So there's also things that, happen suddenly or are temporary that are really important to see a physician or an ENT or an audiologist quickly. So the first one is sudden hearing loss. So that can be a noticeable change in hearing in one or both ears that happens quickly. So it doesn't have to be a full complete loss of hearing. It can just be a fluctuation of hearing. When I am testing someone's hearing, that's already an established patient with me, if they've had a significant drop in hearing since the last time I tested them, that's a red flag to me that I need to refer them out. So you really need to go and get that checked immediately when you notice that change, so that either they can be treated with steroids or something that might help bring that hearing back, or the right referral can be made. Just like Tara said before, her father had a sudden change in the hearing loss, or a significant drop in one of his ears, and an MRI was eventually ordered, and they found that brain tumor. If I see a significant drop in a patient's ear that wasn't there the last time I tested it, I'm referring them out for imaging to make sure that everything is the way it should be. And more times than not, it is all okay, but you want to just make sure and cover all of your bases just to make sure that everything is the way that it should be, and there's no underlying cause for this change in hearing. Also, pain or drainage is something that you really need to get checked out quick, so that it can be treated. You don't want to let your ear pain or ear drainage sit for too long. Another one is ear fullness or pressure. So that feeling like you're going up in an airplane and you can't clear your ears. If it's like that a lot, you want to go and get that checked out to make sure there's nothing that you can be doing to help the symptoms. And then lastly, tinnitus. And tinnitus is a big one that I see very often. If you have a sudden onset of tinnitus, or maybe you've had tinnitus symptoms for a while, but it's getting to the point where it's extremely bothersome, it's affecting your day-to-day life, or it's keeping you from sleeping all night, you want to get that checked out, and you want to discuss different treatment options so that you can get back to your normal day-to-day life and not have this symptom overpowering your life. All right, So lastly, I just want to have this all come together and talk about working towards treating the whole patient and not just the symptom. So first, interprofessional relationships are so important. So patients come to my practice, they present themselves with all these different kinds of conditions that require medical management. And a lot of the times it's beyond my knowledge, beyond my skill set, and beyond my scope of practice. So I am trained to identify these conditions. I am trained to understand the impact it has on a patient and where to appropriately refer them so I can help co-manage that condition with their primary care physician or any other professional. Working with primary care physicians like Dr. Akampora are so wonderful because they have the same value. They understand how important it is to work with different specialty professionals so that we're really making sure that we're giving our patient the best treatment possible, and we're covering all of our bases, and we're trying to help treat every little bit, because the ears don't stand alone. The ears impact the whole body, and other parts of the body impact the ears. So we all need to work together to make sure that we're giving our patients the best care. And we're really trying to treat everything so that we don't exacerbate any other symptoms. So looking at things like cardiovascular disease or diabetes, I know I can't cure that. I can help with the hearing loss and treat with hearing aids, and I can refer them out, but I can also work with the other professionals to give healthy tips. I always recommend healthy exercise, healthy diet, because that can help with those symptoms for the disease, the cardiovascular disease, which can in turn help with the symptoms of the hearing loss. So just really communicating with everybody involved and working together to make sure our patients know what they can be doing to help their symptoms as well. And another example is tinnitus. So I have lots of patients with tinnitus that I can treat these symptoms and I can help with tinnitus training, but I can't help the other symptoms that can exacerbate the tinnitus. So things like stress, depression, not sleeping, anxiety, all of those things exacerbate tinnitus. So if they're not being treated, then the tinnitus is just getting worse. So I'm often referring my tinnitus patients out for cognitive behavioral therapy, to go and get their medications looked at by a pharmacist to make sure that nothing that they're taking is impacting or exacerbating tinnitus symptoms. I am making sure that maybe if they're not sleeping well, they're getting that treated, so that their actual treatment of tinnitus is better and it doesn't exacerbate any of their symptoms. So really, at the end of the day, it's our job as health professionals to work together, so our patient gets the best care possible, and we're making sure that we're really not just treating the symptom of hearing loss or tinnitus, but we're getting to the root of the problem and trying to help them the best they can from the start. All right, thank you. Any questions?
Thank you, Dr. Palmiere. And yes, well, we do have time for some questions. The best way to do that is if you're watching us on Zoom, you'll see a little Q&A box on your screen. You can use that to ask questions for Dr. Palmiere. Dr. Palmiere, I guess just as we're waiting for people to get their questions in, some things that I have. Can you tell us why it's important to see an audiologist rather than just a technician? Why come to someone who's specially trained like yourself?
So the biggest thing between an audiologist and a hearing aid dispenser is their medical side, their medical training. So I've been trained to look for certain medical problems and to know when to appropriately refer. And from the start of from that appointment, red flags are going up, and I'm thinking, what else could be going on? Where can I be referring to? Or, or is this just an aging problem and there's no need to refer? But I'm really doing detective work throughout my appointment to make sure that everything else in that patient's health and medical history is lining up, and that they're getting everything taken care of that they need to be taken care of.
My dad is a good example of that. He is out of state, so we didn't know what he was doing, but he went to a hearing technician. I'm confident that if he'd gone to an audiologist, we probably would have gotten a diagnosis a good month earlier.
Yes. The first day of grad school, you learn that if there's a sudden change in hearing, that's a big red flag to refer, right? It's something that's not normal. It's not supposed to happen. And it's not just something that I take lightly and just reprogram a hearing aid and send you on your way, because again, it can really result in something or be a precursor for something bigger that's going on.
Why do you think some people wait so long to go see a physician about their hearing loss?
I think that really it starts with I think that there's a stigma with hearing aids, and it's not the same with glasses. Unfortunately, people don't look at glasses and think, "Oh, you're old," but they look at hearing aids, and in the old times they thought, hearing aids made you look older. It's a vanity thing. But nowadays the hearing aids are so small, they're so connective, that stigma has been starting to go away. And I can say that I have been seeing younger and younger patients coming in to start getting treatment for their hearing loss earlier, because it's not as big of a deal anymore. I do recommend that at the age of 50, you start coming in every year for a hearing evaluation, even if you don't feel like you have a hearing loss, because it gives you a good baseline of what your hearing is. And then I will know when I'm looking at all consecutive hearing tests, whether things have changed, whether it's getting to the point where treatment of hearing loss needs to start happening, or if something weird is going on from looking at the baseline measurement. And then if you have a family history of hearing loss, you should start getting your hearing checked even earlier, because you're predisposed to a hearing loss if your family members, your mother, your father have had that problem.
We have a question from a viewer. They're asking, they're a patient that has had years of tinnitus. What sequence of referrals or suggestions might you offer to them?
So it depends. If it's long-standing tinnitus, I usually start with asking, what other problems are you having? Or is it just that symptom? Do you have problems with sleeping? Do you have depression, past of anxiety? What other medications are you looking at or are you taking right now? And I start to look at all of these things, and dependent on what your answers are, I will know where to refer. If nothing else is going on and it's just been a long-standing history of ringing in the ears, and you're just bothered by it, then I'll start talking about the rehabilitation of tinnitus and how I can help with the treatment. So that can be anywhere from using sound machines to using hearing aids, because the fact of the matter is tinnitus, 80% of people with tinnitus have an underlying hearing loss, and that's the cause of the ringing in the ear. So once you treat the ringing in the ear, the ringing or the tinnitus becomes less present. But the exacerbation of the symptoms can have to do with a plethora of different things. So knowing what else is going on in their medical history, I'll know where to refer to help with those symptoms.
As we're waiting for more questions, one of the things that we heard you talk about was comorbidities, and how lifestyle changes can affect hearing. Is there any, do you have any evidence that diet affects hearing, or how does diet affect hearing in your opinion?
It's not, there's no evidence for diet and hearing, but there's evidence for things that are caused by poor diet that can affect your hearing. So again, with cardiovascular problems, you start to have cardiovascular issues, that can really, really affect hearing, right? So if you make sure you have a healthy diet, exercise, that can help with all those other problems in the body, which can in turn help you from maybe having a hearing loss that didn't need to happen before.
All right, I think that's all the questions we have. Tara, do you have anything that you want to ask Dr. Palmiere before we head out? All right.
I appreciate you taking the time with us today, and also how much I appreciated your comment about how all these things can be very interrelated. And that's the way we treat our patients. We kind of look at 5 areas of health, including diet, exercise, sleep, stress, and balance. And you've mentioned at least 4 of those 5 as affecting people's hearing. And that's why we work so well together is, again, we don't treat a symptom, we treat the whole person.
Yes, I agree. That's great.
All right. Dr. Palmiere, just real quick, can you let everyone know how they can get in touch with you if they have any other questions or if they want to possibly schedule an appointment if they're having difficulty with their hearing?
Yes. So hold on, there we go. Sorry, I haven't moved. So I am located in the Piper Glen Shopping Center in Charlotte, North Carolina by the Trader Joe's. And you can go to audiologyofcharlotte.com and my information will be there. We do offer free hearing evaluations. So your first appointment is completely free. So please feel free to reach out to me and schedule an appointment. I would love to see you all and get you on track for better hearing and better overall health.
All right. Thank you so much. And yes, if you want to learn more about WelcomeMD, you can go to welcomemd.com. It's WELLCOMEMD.com to learn more and schedule a complimentary meeting with one of our physicians, either in Charlotte or Richmond. So thank you to everyone who tuned in today. Thank you so much for joining us, Dr. Palmiere, and we will see everyone again soon.
Bye. Thanks so much.
Thank you.